Welcome everyone. Thanks for joining us for today's webinar titled Type 1 Diabetes Through the Lifespan. This webinar is supported by Sanofi Lexicon Alliance. The presentation is educational in nature and contains no promotional or product information, and continuing education credit is not available for this activity. If you would like to ask a question during the presentation, please feel free to type it into the Q&A box on your screen at any time, and we'll answer as many questions as possible during the Q&A session at the end. So with us today is Gary Shiner. Gary is a certified diabetes educator, master's level exercise physiologist, and person with type 1 diabetes since 1985. He's the owner and clinical director of Integrated Diabetes Services, a private practice dedicated to helping children and adults with insulin-dependent diabetes. Gary has authored 6 books, including Think Like a Pancreas, and lectures internationally on a wide array of topics in diabetes care. In 2014, Gary was named the AADE Diabetes Educator of the Year. So now I will turn it over to Gary to begin.
Well, thank you very much, Megan. It's an honor to deliver this presentation, having lived with type 1 diabetes for about 34 years now. And one little trivia point, I was diagnosed in a small town in Texas called Sugar Land. It was kind of an ironic place to get diabetes, but nonetheless. So what we'll cover over the next 45 to 60 minutes, first off, we'll make sure everybody's on an even playing field in terms of the pathophysiology related to type 1 diabetes. And we'll discuss the various stages of growth and development and how type 1 diabetes care and management is affected, and specifically how we as diabetes care and education specialists can adapt our teaching and management approaches to meet the needs of people at these various stages. And we'll finish up just talking about the state of research in type 1 and where things are currently and what things look like on the short-term horizon. So we're going to start out with a quick question for everybody. True or false? Type 1 diabetes is caused by obesity, heredity, and a lack of exercise. So go ahead and mark your answer in the box. Okay, it looks like this is a pretty savvy audience because nobody said that was true. That, in fact, is a false statement. As you all know, type 2 diabetes is often caused by obesity, heredity, and a lack of exercise, but not so in the case of type 1 diabetes. This picture, I don't want you to jump out of your skin looking at this. When I think of type 1 diabetes and the underlying cause, I think of a mutiny. And that's what this photograph is designed to represent, is a mutiny. Type 1 is an autoimmune condition. Essentially, the body's own protective process, something that's supposed to keep us from being affected by outside forces like viruses and bacteria and allergens. Our immune system accidentally attacks part of our body. In this case, it's the insulin-producing cells of the pancreas. There are a number of other autoimmune conditions, such as Hashimoto's hypothyroidism, celiac, psoriasis and eczema, there's and many others. But autoimmune conditions are really a mutiny. It's the body's own internal defense mechanism turning on the body itself. When the beta cells of the pancreas are destroyed, the lack of insulin production produces very high glucose levels in the bloodstream. The body's cells starve for fuel, and it can lead to ketoacidosis in an extreme state. Diagnosis for type 1 diabetes is very similar to diagnosis for type 2. An A1C above 6.5, fasting glucose above 126, or above 125, I should say. 2-hour postprandial glucose above 200, or any random glucose above 200 is enough to diagnose diabetes of any form. We distinguish it from type 2 in a number of ways. in type 1 diabetes is often diagnosed at a younger age. There are usually acute symptoms of polyuria, polydipsia, and polyphagia. And DKA may be present, but you see the maybes next to all of those. There are a lot of possible other things that can be taking place. Type 1 diabetes can be diagnosed in middle or even older age. The symptoms may not be present, and DKA may not be present either. I know when I was diagnosed, my glucose was excessively high. It was in the 600-700 range, but I was not ketotic, which surprised my doctor, but nevertheless, I had lost a lot of weight, but the symptoms really can vary from case to case. The real definitive way of defining type 1 diabetes is the presence of autoimmune markers. And typically, if at least one of these is present, that's usually enough to make the differentiation between type 1 and type 2 diabetes. Islet cell autoantibodies, insulin autoantibodies, GAD antibodies, tyrosine phosphatase antibodies, or zinc transport, any of these antibodies is almost always an indication that type 1 diabetes is the official diagnosis. And just in case no one's not fully aware of the function of insulin, to put it in the simplest terms, insulin facilitates the uptake of glucose by the body's cells. It sort of unlocks portals or doors that allow glucose to shuttle into the cell. There are a number of steps that take place in between insulin attaching to a receptor and glucose entering the cell, but in simplified terms, this is all anyone really needs to know about it. In the etiology of type 1 diabetes, there usually is a fairly long process, a drawn-out process that takes place. So an individual who starts out with normal beta cell mass and can produce plenty of their own insulin, but may have a genetic predisposition, specifically to develop the antibodies that attack. There has to be a trigger of some kind. We'll discuss in a moment what triggers the immune system to start attacking these cells. People can go for years or even decades with antibodies, but still continue to produce sufficient amounts of insulin. But that trigger will initiate the immune system to begin attacking the beta cells of the pancreas. And typically the first thing we see lost is called first phase insulin response. And this is the insulin that the body produces right after a meal when glucose rises sharply. So it's more or less a bolus of insulin produced by the pancreas. Over time, with continued loss of beta cell function, second phase insulin response is also lost. And that's usually when we see the clinical onset of diabetes where symptoms appear. A person may need to lose 80 or 90% of their beta cell mass before the symptoms of diabetes appear. So those remaining 10 to 20% of beta cells can produce enough insulin to keep the symptoms minimized. Still, the type 1 diabetes is in development, but it's usually not diagnosed at that point because symptoms just haven't shown up. Let's talk about the triggers for type 1. So we have an individual who has antibodies against insulin or GAD or islet cells. What triggers those antibodies to start their attack? Because there are people who will sometimes have these antibodies at a very young age and may not develop type 1 diabetes for 30, 40, or 50 years. One of the prevalent theories is that certain viruses contribute to the attack on the pancreas. There may be toxins in the environment that a person is subjected to. There may be a major stress in a person's life, or perhaps there is some inherited susceptibility that's where this trigger is going to just occur at a certain age biochemically throughout the body, and it's going to trigger that immune attack. We don't know for certain. The virus theory is gaining some greater hold. There was some recent research on the rhinovirus, and they studied rhinovirus incidence in Australia and found that the incidence of type 1 diabetes was very closely linked to people who had rhinovirus at an earlier age. So there is growing evidence that may be what's behind the triggering the immune system to attack those beta cells. There's some other features that are unique to people with type 1 diabetes. I mentioned that it often occurs at a young age, but it's certainly not a requirement. I'm sure many of you remember when we called type 1 juvenile diabetes. We don't use that term anymore. First off, because most children with type 1 grow up to be adults, and second, because half of the diagnoses of type 1 diabetes actually occur after age 18. So it's not a juvenile onset disease. It just typically occurs at a relatively younger age. It represents about maybe 5% of the total diabetes population, perhaps even less than that. Right now, there's about 1.25 million people in the U.S. with type 1. The rate at which type 1 diabetes is being diagnosed does exceed population growth. So there is something to the gene pool whereby people with the hereditary factor of autoimmunity are having children, and they're at a relatively higher risk as well. We typically see symptoms come on in an abrupt fashion. Once the beta cell mass gets below that critical level, the symptoms come on pretty quickly. The blood sugar tends to shoot up fast. Glucose toxicity will often kick in when glucoses are chronically elevated. In this case, it can happen very quickly, and things escalate in a hurry. There's often a honeymoon period after initial diagnosis, where when somebody is administered insulin by injection, it kind of rests those remaining beta cells and allows them to keep producing insulin for weeks, months, or sometimes even years. People with type 1 diabetes are susceptible to ketoacidosis. We don't tend to see DKA in people with type 2 because most can still produce their own insulin. We see ketoacidosis in people who produce none of their own insulin and have either missed or have spoiled insulin that they're taking. And people with type 1 depend on insulin for survival. There are many people with type 2 who take insulin. We call them insulin requiring. They require the insulin just to manage their glucose. They're not dependent on it for survival the way people with type 1 are. The goals of treatment in type 1 diabetes, and we'll talk first mainly about hemoglobin A1C levels. In A1C below 7 is recommended for most patients with type 1 diabetes. We'll break this down to get a little more detailed in a bit. Children and adolescents, generally, we're looking for A1Cs below 7.5. In the preconception phase, we strive for A1Cs down in the low 6s and then below 6 during pregnancy. The Association of Clinical Endocrinologists recommends A1Cs below 6.5 for pretty much everybody. And we're all in agreement that part of the glucose management involves minimizing hypoglycemia and all of the risks associated with that. Hypoglycemia can be deadly, but it can also cause a lot of chronic and acute problems for the person experiencing it, both from a behavioral standpoint, a performance standpoint, and increasing a variety of other risk factors. This is a more detailed look at the various goals that have been established by the American Diabetes Association. And this is information that's being updated on a regular basis, and a lot of this stems from the fact that we're looking more at quality metrics rather than just the A1C now. So target range is considered a very important metric, and how often we like to see glucose within that range. For most people with type 1 and type 2 diabetes, we like to see glucose in a target range at least 70% of the time, and minimize it, less than 4% of time below target thresholds that have been set. We also want to see minimal variability, and that's measured by something called coefficient of variance. If you ever download a patient's pump or meter or CGM, you can see what the standard deviation is of their glucose data. If you divide that value into their average, you come up with a coefficient of variance. And generally, we like to see that coefficient of variance at about a third or less. So if somebody's average glucose is 150, we'd like to see their standard deviation less than 50. That would indicate that their glucose is fairly stable. It's not bouncing around into extreme highs and lows very often. In older or higher risk patients, the goals are a bit more conservative. And during pregnancy, we have much more aggressive goals. The hypoglycemia goals generally stay the same, but we're not as tolerant of elevated glucose levels during pregnancy. Other clinical goals, and similar to type 2 diabetes, we have to think about more than just glucose levels. We have to be concerned about a patient's lifestyle, their cholesterol, their blood pressure, et cetera, because the complication risks are very similar. We do tend to see more microvascular complications in type 1, but macrovascular complications do occur at a much higher rate than the general population. So we want to manage blood pressure. For those who have multiple risk factors for heart disease, blood pressure below 130 over 80 is actually recommended. HDL levels above 50 and triglycerides below 150 are recommended. Achieving and maintaining an appropriate weight. Keeping the diet low in saturated and trans fats, regular exercise. And another biggie is timely labs and exams. We have great methodologies now for preventing complications if we can catch them early. So timely lab work and timely examinations with ophthalmologists and et cetera are pretty important. And also a part of the goals of treatment is considering the patient's personal goals and considering their quality of life. So we have to find a balance between the amount of burden placed on them and what's needed to manage the diabetes successfully. Here's your second polling question. And put your answer in the box. True or false? It's really just carbohydrates that make blood sugars go up. Back when I was diagnosed, this is all they told us, was just watch your carbohydrates, watch your sugars. Okay, close that. Once again, we've got a savvy audience. Nobody fell victim to that question. That is a false statement. Management of diabetes involves a lot of variables that can go on at any given time. Nothing exists in a vacuum. We have multiple factors that can raise glucose and multiple factors that can lower it. In a person's diet, the carbohydrate has the predominant effect out of anything that's eaten. But protein can also contribute to a glucose rise, particularly in people on low-carb diets. Fat can also contribute to a glucose rise by causing insulin resistance. In addition, we have a multitude of counter-regulatory hormones that raise blood sugar. And these include growth hormone, stress hormones like cortisol and epinephrine. So there's a variety of hormone states that can cause blood sugars to go up. And then lowering glucose, we have insulin. We have physical activity, which improves the body's sensitivity to insulin and increases glucose metabolism. We also have the effects of alcohol, which impair the liver's secretion of glucose. So there's lots to consider at any given time. So when we're training patients on how to manage diabetes, we have to take everything into account. If we only focus on one or two of these items, we're going to come up short. And of course, measuring glucose is a very important aspect of managing and living with type 1 diabetes. But glucose data in and of itself isn't very helpful unless we have some contextual information. We need to understand what are they doing, what are the other factors that are affecting their glucose. So let's take the leap from there to going through some of the various life stages and how diabetes management, care, and treatment are going to be influenced. I'm proud to say I've made it through several of these stages so far. I was diagnosed at the tail end of adolescence. I was in college already, but I've been through the young adult process, been in adulthood for a while, and I'm creeping up on that advanced age thing. I'm not excited about it, but there's no avoiding it. But hopefully most of your patients will see their way clear to advanced age with their diabetes. So let's start out with the new diagnosis. And remember, diagnosis of type 1 diabetes can and does occur at any age. We've seen diagnoses in children just a few months old. We've seen diagnoses in people in their 80s. So this can occur at any time. There are certain issues that are common regardless of the age of diagnosis. First, we have to make sure that if the patient is ketotic or in ketoacidosis, that has resolved. Typically, that's done through careful administration of fluids, of insulin, and of various other nutrients that are necessary to stabilize glucose levels and keep pH levels carefully balanced. There's always going to be a state of what we call diabetes overwhelmus. There's a great deal of information to absorb right at the beginning, and as you can imagine, it can be overwhelming to many people. There is a need for emotional support. Type 1 diabetes is not something that's going away anytime soon. It requires major lifestyle changes, careful medical management. There's a lot of detail involved, and emotional support is going to be necessary. It's very important that patients have 24-hour clinician accessibility when they're newly diagnosed. If they're not hospitalized, they have to have people to reach out to. And family and caregivers need to be involved at the beginning so that they can understand what's necessary to manage diabetes and also what their partner or their child or their parent happens to be going through. Traditionally, we teach survival skills to those who are newly diagnosed, and we discuss goals of treatment. Why are we focused in on managing glucose levels? What are the short-term and long-term consequences if it's not managed? I always like to take a positive spin on that, though, and focus on what can be accomplished if you do manage it, and how long-term you may actually benefit from successfully living with a disease like diabetes. Patients have to learn how to administer insulin, and usually we start out with a pen or a syringe. They have to be able to monitor their glucose, and even though CGM is growing in the marketplace, every patient has to be able to check their glucose with a finger stick meter. Although we'll often now think about starting people on both simultaneously. But the meter is going to be necessary, if not to calibrate the CGM, then just to make sure they have a way of monitoring when and if the CGM is not functioning, or if the accuracy is in question. Since insulin doses are usually started on the conservative side, hypoglycemia isn't a major risk at the beginning, but we can't ignore the possibility. So patients have to be taught about symptoms and proper treatment. And initial meal planning, just understanding the role that carbohydrates play and looking to distribute carbohydrates throughout the day in reasonable portions. And then the follow-up training is when we get into a lot more of the finer points of living with and managing type 1. And that includes things like teaching patients how to self-adjust their bolus insulin doses, evaluating how they respond to exercise and teaching them to adjust properly, utilizing newer technologies like insulin pumps, CGM, and all of the different software that can be utilized with those. Education on ketone testing and sick day management, and also knowing more about the complications and more importantly, how to prevent the various complications of diabetes. Earlier I mentioned something called the honeymoon phase, which most people experience after diagnosis. I don't have any stats on the percentage that experience this. Unfortunately, I did not experience a honeymoon until I was married and had an actual honeymoon. I didn't really have any diabetes honeymoon after my diagnosis. And it's probably because I went a long time with symptoms before I started getting my treatment. And by that time, my beta cell mass was probably down to 0. But the honeymoon phase means that the pancreas is still producing some insulin. And once insulin injections begin after diagnosis, it has a sort of a resting effect on the existing beta cells, and the pancreas is able to keep putting out insulin for some time. This can typically go on for weeks or months, but there have been cases of it lasting for years. The honeymoon is prolonged and more prevalent in those who are diagnosed very soon after symptoms appear. It's also prolonged in those who exercise regularly. It seems that regular exercise has a sparing effect on insulin requirements, and the amount of strain on the beta cells is lessened. So the pancreas's ability to keep producing insulin seems to go on longer in type 1s who exercise on a consistent basis. I mentioned that first phase insulin secretion earlier. That's what's usually lost first. So blood sugars after meals will start to pop up quite high. And then the second phase, the basal or background insulin secretion, is lost. And that's when we start seeing glucose levels rising dramatically overnight. And patients will start waking up with above target readings. The dosing plan has to be updated. We have to roll with the changes, so patients should be communicating on a frequent basis. Usually we like to look at data weekly to see if and when doses need to be reduced and then later taken back up. But I think it's important to explain the temporary nature of the honeymoon phase to patients so that they don't get it in their minds that if they do what they've been doing, they're going to stay off of insulin. That's not going to happen. They just need to understand it. We don't know exactly when, but eventually the pancreas will lose all of its insulin production ability, and injections and pumps are going to be required. So now let's start at the earliest age and some of the key issues and some of the adaptations we may need to make in our way we practice diabetes care. With very young children, infants and toddlers, we have to be very concerned about hypoglycemia, much more so than in older children and in adults. There is evidence that the brain is affected. Cognitive abilities long-term can be influenced by hypoglycemia. This doesn't mean that a few minor bouts of mild low blood sugar are going to doom a child, but severe hypoglycemia, particularly prolonged severe hypoglycemia, has a strong likelihood of causing some long-term damage. At this age, all tasks are going to be performed by caregivers. Obviously, the patient's not going to have the ability to take care of their own diabetes in any way. Children this young can be finicky eaters, which throws a wrench into insulin dosing schedules. They're also very sensitive to small doses of insulin. Insulin action curves tend to be a bit shorter in very young children. They metabolize the insulin and excrete it a little sooner than adults do. The limited geography, this doesn't mean they're only located in certain cities. This means the amount of skin space for injections or for pump infusion sites or for sensors is limited just based on body size. Physical activity is not scheduled and planned. It's all spontaneous types of activity. We also have a challenge with children developing lots of minor illnesses and infections, inner ear infections, et cetera, that can come and go constantly. And that can certainly affect glucose control. Some of the strategies that we apply to these young children, we often set targets that are a little bit higher than we would in older children. And it's not unusual to aim for a glucose of 150 as a set point and to accept glucose values between 100 and 250 in children this age as being reasonable. Family and caregivers have to be educated on every aspect of diabetes care, including sick day adjustments and how to manage glucose and who to call and when illness takes place. Continuous glucose monitors can be used effectively in young children, but the alert thresholds need to be set much higher than they would in adults. We don't want to wait until glucose is below 80 or 70 to receive an alert. You may need to know when it dips below 110 or 100. Taking insulin after meals is reasonable once you know how much food is consumed. That's when it's really safe to calculate and give a dose. Although some people are able to administer a small dose before eating and then give the balance of the insulin after the meal. Because of the sensitivity to insulin, insulin pumps are a very good option. They can deliver in tenths or 20ths of a unit. If you're going to use pens, half-unit pens are preferable, syringes with half-unit markings as well. And it's reasonable to dilute insulin so that families can dose in more precise increments. Because of a lack of sub-Q fat, giving injections at an angle can be useful. And also using sites other than the fingertips for lancing, using the heel of the hand, for example. Rotation patterns need to be established right up front for injections and as well as infusion site changes. We don't want sites being repeated too often because lipodystrophy can easily develop. And we also instruct on supplementing extra carbohydrates with physical activity. It's not just exercise per se, but just playing, crawling, lots of walking. These types of things are going to require a little extra carbohydrate to prevent hypoglycemia. When kids get a little bit older, school-age kids, we have to be concerned about who's taking care of them in the school setting. Is it a nurse? Is it a teacher? Is it an aide? Or is it the parent? Extracurricular activities become very common in kids this age, more so than ever. Everything is organized now. Kids will have parties, they'll have sleepovers. We have a little issue called growth, where as a child produces growth hormone, their insulin needs go up. As they get larger, their insulin needs go up. We see this particularly at bedtime when growth hormone begins to surge. Eating patterns can still be quite inconsistent at this age as well. It may not be as unpredictable as in a toddler, but with young kids, they don't always eat what's put in front of them. So as diabetes care and education specialists, we should work with these families in developing a 504 plan so that everyone knows who at school is responsible for what. Education may need to be provided for nurses and coaches and teachers and any other family members who might be spending a lot of time with the child. It's good to define age and ability-specific tasks so that families can slowly incorporate the child in performance of some of those tasks. Using mobile technologies is very helpful for the parents to be able to monitor their child, not only their glucose levels, but also their insulin administration. This is a good age to focus on scheduled meals and snacks. As you'll see when we talk about teens and adolescents, grazing can be a major problem with glucose control. It's very difficult to manage glucose levels in people who graze. Having more of a regular schedule where meals and snacks are spaced out in a reasonable amount is very useful. Adjustments to both food and insulin for sports activity can take place at this age. And it is important to help parents strike a healthy balance as far as how much work is too much or when they need to pick up the pace a little bit. And parents also need to understand what's realistic to accomplish, so it's worth revisiting what the acceptable glucose ranges are and how often it's reasonable to be in that range. Parents will sometimes beat themselves up a little bit too much when any blood sugar is not close to normal. Teens and adolescents. Key issues. Where do we start? There are multitudes of issues with kids this age. We have eating out, and in particular a lot of high-fat foods, being on the road or at friends' houses without caregivers, the introduction of menstrual cycles, sex, drugs, alcohol, attitudes that kids have, states of rebellion, physical activity levels that can vacillate between extreme activity and a complete lack. And we also see some significant insulin resistance at this age. It's similar to what we see in pregnancy, with insulin resistance building up dramatically in adolescence. So these are some of the strategies that we found to be useful in working with kids this age. We always like to focus on things that are pertinent to that individual. blood sugar levels generally are not very important to teenagers, but sports might be, or the ability to have good friendships might be, or doing well in school might be important to them. So we always try to translate glucose control into how it's going to help them in those specific areas. Establishing structure within the family and with the caregivers is very important. There's certain non-negotiable rules, things that have to be done on a daily basis, and then there should be immediate repercussions when those responsibilities are not met. Education must be provided on the effects of things that legally kids aren't supposed to use, but we all know that they have access to them, they're tempted, and they may use them, so they need to understand the effects that they can have, not just on their diabetes, but on their life in general. As soon as menstrual cycles begin, young ladies need to be educated about the risks associated with childbearing. They may need to be provided with adjustments related to their menstrual cycle as well. Most girls have very irregular, erratic menstrual cycles, but they may notice elevated glucose levels beforehand or low glucose the day their cycle begins. It's usually a good idea to involve teenagers' friends in their sessions with you so that they understand, so that they have proper support. And insulin's going to need to be ramped up on a regular basis. And from that standpoint, you got to consider the size of their pump, how much insulin their syringes hold, and possibly consider the use of concentrated forms of rapid-acting and long-acting insulin so that they're not having to inject quite such a large volume. And there are some food-specific issues. Go back to this grazing issue. It is a problem. We want to do our best to have them avoid grazing, so spacing out of the feedings, 2.5, 3 hours apart is ideal. Emphasize the importance of filling foods that are going to satisfy their hunger, rather than the kind of foods that digest extremely fast and leave them hungry again 20 minutes later. Teens should be taught how to estimate carbs. They're eating on the go a lot, lots of cafeteria food, lots of restaurant food, food at friends' houses, so they should learn how to estimate carbs effectively. They should also learn how to make adjustments for high levels of fat intake, whether it's an insulin adjustment, a physical activity adjustment, or learning how to make lower fat choices because of the effects that it can have. Here's another question for you. True or false? Based on hemoglobin A1C, the teenage years are associated with the worst glucose control, specifically based on hemoglobin A1C. Okay, thank you for submitting those. So about 70% of you said that statement is true, and about 30% of you said it was false. And the correct answer is it is false, surprisingly. Young adults, talking ages 18 to 25, tend to have the worst control of glucose of any age group. A1Cs tend to be the highest. Episodes of hypoglycemia, severe hypoglycemia, are highest as well. Most young adults have been kicked out of their pediatric diabetes care into the quote-unquote real world of adult care, where they don't have quite the hand-holding that they had in a pediatric diabetes program. Young adults are often living independently for the first time in their lives. They're having to deal with things like health insurance for the first time. They have competing priorities, and this probably is one of the major factors that is affecting their glucose control. It's all the other priorities in their lives. And they're more subject to engaging in risky behaviors than we see in other age groups. Some of the strategies in working with young adults, they should be educated on how health insurance works, how prescription plans and supply orders are going to work. It's ideal to provide them with a structured transition program from their pediatric care to adult care. Sometimes that involves the pediatric providers staying involved in the patient care for a period of time, and having adult providers who have some expertise who work with young adults. Roommates and partners need to receive education since they're going to be spending quite a bit of time with the patient. You want to make sure that the patient is maintaining regular contact. I found this to make the biggest difference, particularly with college-age students and young adults. Those who lose contact with their providers and might go a year or more between seeing them tend to have serious issues with their glucose control. Those who stay in regular communication, who have regular visits, who have their data looked at regularly, tend to have much better control. And you'll probably need to revisit the sex, drugs, rock and roll conversations. And obviously pregnancy can be part of the mix in there as well. Speaking of pregnancy, during pregnancy, we're going to have to establish a whole new set of glucose management goals for patients. Postprandial control becomes vital. There's a lot of evidence now that postprandial peaks in glucose will cause hyperglycemia in the baby, and the baby will actually urinate out glucose and into the amniotic fluid and drink it again, so it can cause extreme macrosomia. Insulin requirements are going to change dramatically. We usually see a little bit of a drop-off in the first trimester and then a steady climb for the next 6 months or so. We have issues with nausea and vomiting in most women. We have abdominal distension where injections or infusion sites are placed. The baby's at risk due to high blood sugar. The baby's at an extreme risk if the mom goes into DKA or has an accident related to hypoglycemia. The mom is at risk of exacerbating any underlying complications. See the potential for gaining excess weight, severe hypoglycemia during that first trimester. And this is a phase when the pancreas springs back to life a little bit and is able to produce some insulin again. And also postpartum issues with glucose control. So there's a number of strategies. Preconception counseling is critical. Women who go into a pregnancy with very high A1Cs are really putting their baby at risk for neural tube defects. By the time they realize they're pregnant, a lot of neural tube development's already taken place. Weekly adjustments to insulin are often required. Use of a continuous glucose monitor and an insulin pump have been shown to improve outcomes. And potentially now use of a hybrid closed-loop system, although you have to be wary about which systems used because the targets vary. It may not be feasible to achieve sufficiently tight control with some of the hybrid closed loops that are on the market. High blood sugars have to be managed very aggressively. Ketone testing has to be done with any suspected high blood sugar, any peculiar high reading. Bolus timing is critical to help manage post-meal glucose levels. Patients have to be taught about site options, alternative site options other than the abdomen during the third trimester. They have to be provided with individualized exercise and nutrition counseling, a labor and delivery plan, and guidance to help them manage their glucose during the postpartum phase. Breastfeeding in particular can cause hypoglycemia, so women need to know how to address that. We'll often teach patients to have a couple of Hershey Kisses when they're nursing. It keeps them very nice and steady. In adulthood, we have some serious issues as well. There are family and work responsibilities that are going to compete with a person's attention and energies. Complications may develop, other health problems may develop that are going to interfere with the ability to manage diabetes. Stress can be quite high. There are financial challenges, being able to afford one's medications and supplies, and often we see weight gain during adulthood in patients with type 1. So setting priorities properly, trying to strike a healthy balance between all of one's responsibilities is a very good discussion to have with patients. Teaching them about when to come in for routine lab work and what exams are required. Depression screenings are good to administer at this age, and also screening for potential burnout. Teaching patients about how to reduce their risks for macrovascular disease. And that includes quality exercise planning, finding a healthy caloric balance to minimize weight gain, and providing all the resources that are available from both public and private sources to aid with different aspects of diabetes self-care. A number of additional issues pop up in advanced age where there's often loss of vision or hearing. Manual dexterity can become a problem. Range of motion becomes an issue in many patients as well. Insulin needs can actually drop off, particularly basal insulin needs in advanced age. There may be nutritional deficiencies, and we'll often see weight loss issues during advanced ages as appetites decrease. Comorbidities can interfere not only with a patient's ability to care for their diabetes, but their mental outlook and their glucose control. And then the caregivers are often have to take charge of a patient at this age. So the strategies, and I have an image here of a book we turn to, a catalog quite a bit called Independent Living Aids. And there's a variety of companies that produce adaptive devices for people with all kinds of health conditions. But be familiar with these. Have this information available for your patients. A customized exercise plan is often needed for older patients just to ensure that they're working out at a proper intensity and duration, and that they know how to manage their glucose when they are active. Individualized meal planning is necessary. As I mentioned, we see more issues with undernourishment than overnourishment in older folks. Depression screenings are good to implement on a regular basis in patients of advanced age. Discuss with them the home delivery of supplies and medications. Utilize reminders. Forgetfulness can be a serious problem, so using reminders on a timer, a clock, a watch, a phone can be very helpful. The discussion about home health care and potentially transitions to home nursing or nursing homes also should be brought up at the right time. Last polling question. The artificial pancreas is already available for people with type 1 diabetes. Is that true or false? Looks like we have a pretty good mix here. About 40% of you said that that's a true statement, and about 60% of you said that it's not. Well, the fact is, that's also a false statement. We do not have an artificial pancreas. What we have are called hybrid closed-loop systems. We have systems that can adjust some aspects of the basal insulin delivery, but we don't have anything that will automate glucose control completely, which is what an artificial pancreas would do. Patients are already utilizing adjunctive forms of therapy. Symlin is a product that's been on the market for several years now, and it's replacing a hormone called amylin that's normally produced by the pancreas. And when beta cell loss occurs, you also lose the production of amylin. And amylin's job is to control the rate of digestion. It slows down gastric emptying, it blunts appetite, it also blocks glucagon production. So after meals, it plays a major role in keeping blood sugars stable. So replacing that lost amylin hormone with Symlin, it can be effective for keeping glucose stable after eating. And there's off-label use of some medications currently, but down the road we may see on-label use of drugs like metformin, GLP-1 receptor agonists, and SGLT2 inhibitors to assist the insulin with helping patients with their diabetes care. We have new strategies for preventing the development of type 1 diabetes. Patients at high risk can be screened for those various antibodies we discussed earlier. High-risk individuals includes anybody with a first-degree blood relative who has type 1 or has multiple autoimmune conditions other than diabetes. We know that early detection and treatment improves the long-term outcomes and the honeymoon, prolongs the honeymoon phase. Essentially, catching type 1 very early when there's still reasonable beta cell function and then resting those cells by administering insulin makes management a lot easier for much longer. Research now also shows that use of a certain anti-rejection drug, teplizumab, helps to delay the onset of type 1 diabetes in patients at high risk. Now, this is typically used in patients who receive organ transplants, and it can have some toxic side effects. But when administered at a very low dose for a short period of time, it has been shown to delay the onset of type 1 by an average of about 2 years. And there's also development of antigen-specific vaccines that don't have systemic effects but focus specifically on the immune process that causes type 1 diabetes. So I mentioned hybrid closed-loop technology a moment ago. This we have. We have several systems on the market now, and more that will be coming shortly. This is sort of like the cruise control on your car. When your car starts to slow down, the cruise control picks up the gas and speeds the car up. And when you need to slow down, it alleviates the gas. A hybrid closed-loop system in these terms, you have a glucose sensor feeding data to an insulin pump and an algorithm that dictates how much basal insulin the pump should be delivering. So if the glucose is climbing over a period of time, the basal insulin will be increased. If it's falling, the basal insulin is decreased. It doesn't really touch the boluses per se, and that's why it's still called a hybrid closed-loop system. There's no glucagon in this equation, so these systems can't quickly raise the blood sugar either. That's why we're still quite a ways from a true artificial pancreas, but we do have these hybrid closed loops to kind of help put the blood sugars in range more often. In terms of cures, a number of different avenues are being explored. Beta cell regeneration is being considered, whereby the beta cells that are present in the body can be stimulated and grow and multiply and be able to produce insulin like they once did. Beta cell replacement therapies, where cells are taken either from a cadaver or from bioengineering, the cells can be encapsulated into a packet that protects them against immune system response and hopefully can continue monitoring glucose levels and producing insulin over a long period of time. Controlling the immune system is another key way to cure type 1. In patients who still have some beta cell function, if the immune system is put under wraps, those beta cells can again do their job and multiply and control blood sugar levels. Smart insulin is insulin that actually activates itself when glucose levels are elevated. So imagine the insulin existing inside of a rubber ball that has a slit. That rubber ball slit opens up when it's exposed to glucose, so the insulin can get out. When glucose levels fall, the ball seals up, and the insulin can't be released. That's smart insulin. And then the artificial pancreas is a much more sophisticated hybrid or closed-loop system that will likely involve multiple hormones. In addition to insulin, it may involve glucagon, it may involve amylin as well. You have multiple hormones being secreted to control glucose levels overnight, before meals, after meals, etc. The type 1 diabetes, like I said, it remains prevalent. It's serious. We have well over 1 million people in this country with type 1. It's growing faster than the general population. The implications are very serious. It's difficult to manage. There are acute and chronic complications associated with it, and it plays a serious toll on the people who have to live with it. It's quite a bit of burden involved. But it is treatable, and I think our role as diabetes care and education specialists remains essential in helping people with type 1 diabetes live successfully with their disease. So I'll turn things back over to Megan. We should have a chance to go through any questions that came up.
Yes, thank you so much, Gary. We will open it up for questions in the time that we have remaining, and we've already got a few in, so we'll jump right in. So the first question says, how long does it take to get the test results back for the type 1 diagnostic criteria?
Testing for immune markers usually takes a day or so. it's a fairly common test now that most laboratories can produce. I don't think there are in-office machines for doing immune system marker testing yet.
Wonderful, thank you. The next question says, how do protein and fats increase blood glucose?
Well, protein can cause, gluconeogenesis takes place in the liver, and protein substrates can be used in that process. Again, we don't usually see protein converting to glucose directly if a patient has reasonable amounts of carbohydrate in their diet. But if people are eating very small amounts of carbohydrate or they are avoiding carbohydrate entirely, we'll often see some rise in glucose from their dietary protein. Fat causes insulin resistance, dietary fat, I should say. So when somebody has a very high-fat meal, their liver is going to become insulin resistant, and they're going to secrete more glucose than usual as a result. So that's an indirect effect on glucose levels.
Great, thank you. We have a couple of people asking about the antibody tests. And so just asking if you can talk more about them and if there is a preferred antibody test to confirm a type 1 diagnosis.
Well, honestly, I don't order these tests myself since I'm not a physician. The tests that are most routinely ordered, the GAD antibody is probably the most common one that's looked at. But the insulin autoantibody and the islet antibody is also considered. Those three are the three most prominent or prevalent ones that are considered.
Great, thanks, Gary. The next question says, let me see. Can you elaborate again on the effect of stress on glucose levels? 2 incidents come to mind: illness, surgery, and when adolescents play video games.
Yeah, the adolescent video game thing, I think it causes stress on the adolescent and also their parents. Yeah, the stress can cause 2 different effects. There's an acute effect where epinephrine, norepinephrine production accelerates, and that can cause blood sugars to spike up very quickly and very high. And then there are chronic stresses that cause cortisol levels to be increased, and that'll cause chronic elevations in glucose and a certain degree of insulin resistance as well. Those hormones are produced in larger amounts during illness, as well as during when a person is injured or in pain or going through medical procedures, things of that nature. I know that every time I go to my dentist, I have to raise my insulin dose because my sugars go up, even without eating anything. So I know firsthand what that's like.
Great, thank you. The next question we have here, it says, what is the best answer to give a patient when you're asked, can my diabetes go away?
Once you have diabetes, it's always there, but you can manage it such that it won't interfere with anything you try to do in your life. It shouldn't get in the way. You should still be able to accomplish anything that you want to accomplish. It's just going to require a little more thought and a little bit of effort along the way. You know, it's kind of like having another job that's there all the time, and you just have to tend to it. It's an extra responsibility layered on top of everything else. But there are plenty of people who can manage that and still accomplish great things. I would like to reference folks who are famous, athletes, people in the media, singers, actors, actresses, some very famous people who have type 1 and type 2 diabetes. And obviously, if they can do it, anybody can do it.
Great, thanks so much. And we will take one more question, and it's just asking if you could please repeat the virus that may trigger type 1.
Well, rotavirus.
Wonderful. Thank you
There was a
very
recent
so much.
study out of Australia that indicated that.
Great, thank you. Also, we'd like to thank Gary Shiner for being here today and thanking you all for attending today's webinar. We ask that you please take a few minutes to complete the evaluation survey in order to provide us with your feedback so we can continue to improve our offerings. You can find the link to the survey on the first page of your participant handouts that were emailed to you. This webinar was recorded and will be posted on our website under the Education drop-down and also at the